Good evening, everyone. Welcome to the Spice Route India classroom session for the month of September, which is being hosted by Spice Route Andhra chapter for the month of September. This is the first time after the new council has been formed for Spice Route Andhra. We are having an academic session, and I cordially invite uh, Chair of Spice Route Andhra chapter, Dr. Pradeep, to introduce the moderator for the session as well as the presenter. Over to you, Dr. Pradeep.
Thank you, Vishnu sir. Good evening, everyone. I'm Dr. Pradeep. Currently, I'm working as senior lecturer in NRA Academy of Sciences, Mangalgiri, Andhra Pradesh. Today, we are as a part of Spice Route National session. We are going to discuss about the case presentation of respiratory system. The presenter is Dr. Raviteja, first year resident from RDT Hospital, Andhra Pradesh. From Department of Respiratory Medicine from NRA Academy of Sciences, Mangalgiri, Andhra Pradesh. Very fortunate that we have Aruna ma'am as our moderator. We welcome you, ma'am. And Dr. Raviteja, you can start the session.
Thank you, Pradeep.
Over to you.
Good evening, ma'am. Good evening, ma'am. Am I audible?
Yes, you are audible, Raviteja. Please be a bit louder.
Oh, okay, sir. Thank you. And good evening, ma'am. Myself.
Good evening, Raviteja.
Myself, I'm Dara Raviteja. I'm a first-year family medicine resident at RDT Hospital, Battalpalli, Satyasai district. So today's case presentation. So demographic details: a 50 years old male from Kandukuripalli, Satyasai district, who is a daily laborer, came with complaint of fever for past 1 month, shortness of breath since 10 days, right-sided chest pain since 10 days, cough since 1 week, decreased appetite since 1 week. History of presenting illness: patient was apparently asymptomatic 1 month ago, following which he developed a low-grade fever, intermittent, which is intermittent with diurnal variation, evening rise of temperature, associated with chills and rigors, and patient used to take single tablet of paracetamol for getting relief. Patient also complains of breathlessness and exertion since 10 days, gradual in onset, progressive in nature, more in the daytime, MMRC grade 2, aggravates on lying left side and relieve on supine and right side with no orthopnea and paroxysmal nocturnal dyspnea. Patient had complaint of chest pain which is insidious in onset, gradually progressive in intensity, diffuse dull aching kind of pain over the right side of the chest wall, more in the lower right axilla, which is aggravated on cough and deep inspiration. Patient also complained of cough for past 1 week, gradual in onset, progressive in nature, associated with sputum production, which is mucoid in nature, whitish, scanty in amount, not foul smelling, not blood stained, with no postural or diurnal variation, and no aggravating or relieving factors, not associated with wheeze. No history of halitosis, no history of nasal discharge, no history of sinusitis, no history of tonsillitis, no history of vomiting, no history of loose stools, no history of weight loss, no history of dysphagia, no history of hoarseness of voice, no history of swelling of the lower limbs. Past history, no history of similar. Yes, ma'am. Yes, ma'am.
So your chief complaints are just a minute. Previous slide, please. So patient had shortness of breath since 10 days, you said, right?
Yes, ma'am.
It is of grade 2 MMRC. What is grade 2 MMRC?
Grade 2 MMRC is shortness of breath on when compared to similar age on walking on a flat surface. He feels shortness of breath.
Okay. So what are the grading systems you know apart from MMRC?
Sorry, ma'am.
Any other grading systems you know for breathlessness apart from MMRC?
No. There is a Sherwood John's classification, ma'am.
Okay.
That's it, ma'am.
Okay. So other systems are New York Heart Association classification. Usually, which this grading system is followed for cardiac cases. So there are four grades in New York Heart Association classification. Grade 1 is breathlessness on unaccustomed exertion. Grade 2 on normal activity. Grade other grading systems are Borg scale. Okay, so there are 0 to 10 grades, grading from slight, moderate, severe, like that. Okay, and Sherwood Jones is exclusively used for only asthma.
Oh, okay, ma'am.
So, but if you think it is a respiratory case, it is always better to use MMRC classification only, as you have told. And
Yes,
I assume that you know all the grades of MMRC classification.
Yes, ma'am.
Okay. So come to next slide. And you said patient breathlessness is aggravating on lying on left side.
Yes, ma'am.
Did the patient tell you that it is aggravated on left side, lying down on left side?
So when I asked what are the aggravating factors, like when you get breathlessness, so he said that on lying towards the left side, left lateral, he's having a breathlessness.
Okay. This point I'll come to you again later. Okay, but if patient has told you that it is aggravating on left side, it is fine, but this has to be clarified. Okay.
Okay.
Next slide. Okay, and you also said cough is associated with sputum.
Yes, ma'am. Scanty, very scanty sputum.
Yeah, okay. So when you are mentioning sputum production is there, and which is very scanty, which is not very, I mean, it is negligible, you can omit that point because this will change the entire diagnosis.
Okay, ma'am.
Okay, if it is very negligible and sometimes it can be from upper respiratory tract also, that expectoration. So if it is very scanty and negligible, you omit that point because the diagnosis will be changed. So be careful regarding sputum production. Okay.
Okay.
Then next slide. You have mentioned about sinusitis, you have mentioned about tonsillitis. All these terms you should not mention in history of present illness. it should be always in patient's language. Okay, so never
Okay.
use medical terms in present history. You can just mention that there is no history of sore throat or throat pain. Okay,
Okay.
just
Okay.
like you have written swelling of lower lips, same thing for
Okay.
dysphagia also, difficulty in swallowing. So it should be always in patient's language.
Okay.
Okay. Okay, next continue.
Past history, no history of similar illness in the past. Not known case of diabetes, hypertension, bronchial asthma, pulmonary TB, epilepsy, and no history of contact with TB patient, no previous surgeries. Personal history, there is a decreased appetite. Patient consume a mixed diet. He had normal bowel and bladder function, normal sleep and wake cycle, and he's a smoker. 20 VDs per day since 15 years. That is 15 pack years, and non-alcoholic. Family history, no history of similar illness in the family, no history of TB or any malignancy in the family. Summary, 50 years male non-smoker with 15 pack years presented with complaining of fever since 1 month, associated with chest pain, breathlessness with postural variation present, suggestive of respiratory system involvement. So I would like to examine the respiratory system.
Okay, okay, fine. Again, go back to past history.
Yes, sir.
Okay, you have asked about diabetes, hypertension, bronchial asthma, TB, and epilepsy. Okay.
Yes.
Why epilepsy? Any specific relation with respiratory system?
Due to anti-epileptic drugs, if there is any uh, fibrosis
Okay.
or lung related pathologies of side effects to anti-epileptic drugs.
Okay. Anyways, for any condition, you have to know the uh, comorbidities.
Yes.
Apart from that, epilepsy, CVA, all these conditions where there is loss of consciousness episodes, patients
Okay.
are more prone for aspiration.
Okay. Yes, ma'am.
So, aspiration pneumonias are common following an episode of seizure. Okay. So, that
Okay.
is the reason epilepsy or a bout of vomiting or CVA, all these things we ask even in a respiratory case. Okay.
Okay.
Next slide. And one more thing, you first mention about family history, after that come to personal history always.
Okay, ma'am.
Past history, family history, and when you think that it is a respiratory case, always also take occupational history also
Okay.
in detail.
Is
Okay, you
okay.
have said
Okay.
laborer. So
Labor.
what kind of labor work he does? Because there are many lung diseases which are due to some specific occupations.
Yes, ma'am.
Okay, for respiratory case, occupational history is very important. So can you name some occupational lung diseases?
It's like coal worker, like pneumoconiosis,
Yes.
like, uh, so asbestosis, those
Yeah,
who are working,
asbestosis. Yes.
and
Cotton dust,
cotton
byssinosis.
byssinosis, and
Okay.
those who are
So
working with
these
this.
are specific occupational lung diseases. Apart from that, even asthma, COPD, all these things are also they are more prone in few places where they are more exposed to dust or pollution. Okay,
Okay.
so
Okay.
occupational history is very important. So you always mention about occupational history in the lung case, and finally your history should end with personal history. So family history, occupational history, and then personal history.
Okay.
If the patient is a female, you also include gynecological history
Gyn-
also. And in your personal history, you have mentioned that patient is a BD smoker.
Yes, ma'am.
Okay, so usually we calculate pack years only when the person smokes cigarettes.
Oh, yes, ma'am.
Okay, so whenever a person is smoking any other form like BD or chutta, we
Okay.
calculate smoking index.
Okay, ma'am.
Smoking index is nothing but number of BDs or number of chuttas multiplied by number of years.
Okay, ma'am.
So if it is more than 200, it is significant.
Okay, ma'am.
Okay.
Okay.
Okay. And finally, your provisional was, come to that slide. So you have mentioned fever, chest pain, and breathlessness with postural variation. Why do you think it is only respiratory system? Why is it not cardiovascular system?
So since it is chronic, like since 1 month he's having the complaints, and there is no orthopnea or
Hmm.
paroxysmal nocturnal dyspnea,
Hmm.
so it's not a cardiac, and there is no ascites or pedal edema,
Hmm.
so it's not related to cardiac.
Okay. Do all patients of cardiovascular disease have orthopnea and PND? In which conditions
No.
orthopnea and PND is present?
Uh, in case of pulmonary edema, we'll get a
Yes.
orthopnea.
Yes.
Uh,
And pulmonary embolism?
pulmonary embolism. Yes.
Yeah.
And
Pericardial effusion?
yes.
So all these cases also patient will be having chest pain, breathlessness, and if it is pericarditis, tubercular pericarditis, even fever may be there.
Yes.
Okay. So
Yeah.
you
Okay.
should keep your mind broader. Okay. So you should
Okay.
include, you can start with respiratory system, but you should also examine cardiovascular system
Cardiac.
also. Okay.
Okay. Okay.
Okay. Then next slide.
So, general physical examination. Patient is patient's consent is obtained, and he was in a well-lit room. Patient was conscious and oriented to time, place, person, moderately built and well nourished, BMI of 22 kgs per meter square. So no palar, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema.
Okay. Okay. Next slide.
Okay. Vitals, pulse 84 beats per minute, regular rhythm, normal in volume, normal character, felt in all peripheral pulses, no vessel wall thickening, no radio-radial delay, and no radio-femoral delay. Respiratory rate 18 per minute, abdominothoracic in character, uh, blood pressure 100 by systolic by diastolic 70 Hg, mercury taken in a right upper arm in supine position, temperature 9,
Semua botol tu.
98.6 degrees Fahrenheit,
भाई
and
itu panik
SP
gitu.
saturation
Baru saya
98%
punya.
at room air, and
Okay,
no
okay.
raised JVP.
चलो भाई.
Disturbance is coming, Pradeep.
Baik. Baik. Boleh saya cakap?
Okay, fine.
Can I move to the next slide?
Yes, yes, yes.
So, no asterixis, no gynecomastia,
बस कितना
no Horner syndrome, no small muscle wasting,
ये
no
लीजिए
external markers of
ये लीजिए
tuberculosis,
सब कहाँ दे रहे हैं
no
भाई
external markers of HIV,
सब मत दे दीजिए
no external markers of
अच्छा
pulmonary
उसको खा जाइए आप
malignancy, no
अब क्या
external
करना
markers of sarcoidosis, no external markers of core pulmonary.
Okay. In your after general examination, you have mentioned pallor, icterus, all those
पता नहीं
things.
यहाँ क्या हो रहा है, मम्मी हम समझ ही नहीं पा रहे हैं ये
Some problem is there. Some
Yes.
Actually, there are miscreants who've joined the meeting. Vishnu, are you there?
Yeah, I'm here.
Vishnu, again, people have joined with the name of, iPhone and OnePlus and all. Please remove everybody who's not having a name.
Okay.
Yeah.
Can you all
So-
just rename yourself?
No, we can't wait for them to rename. You remove them because that person is changing names and again disturbing the meeting.
Okay.
Once it was with the Manmohan and once some other name.
Okay.
One iPhone also. Even now it is unmuted. iPhone. Dr. Aruna, could you also please mute yourself?
Please mute yourself.
Hello, everyone unmute please.
okay, I think we can proceed now.
Yes, ma'am, you can proceed.
Yeah. Okay. All these markers, okay, markers of malignancy or markers of HIV, all these things, if at all you are mentioning, it should be in general examination itself. Okay. You should not write all these things after vitals.
Okay.
In general examination, mention about all these markers, and after that you mention about JVP. JVP is not a vital sign.
Okay.
Okay, so there are 5 vital signs: temperature, pulse rate, respiratory rate, blood pressure, and oxygen saturation.
Okay.
Okay, so after general examination, JVP, then vitals.
Okay.
Okay, next slide.
Systemic examination, respiratory system, oral cavity, no halitosis, good oral hygiene, no oral thrush, dental caries on left lower third molar teeth, no tonsillitis, no postnatal drip. Nose, no deviated nasal septum, no nasal polyp, no turbinate hypertrophy, no sinus tenderness. The lower respiratory tract inspection, trachea deviated towards left side, trail sign positive, apical impulse not seen, chest is symmetrical, elliptical shape, no drooping of shoulders, no supra and infraclavicular indrawing or fullness. There is a fullness of intercostal spaces on right side, no kyphosis, lordosis, scoliosis.
Okay. So wait, go back. Okay, trachea is deviated to left side. Okay, you have already mentioned that. Again,
Yes.
you need not mention that trail sign is positive. What do you mean by trail sign?
Is undue prominence of a clavicular head of sternomastoid on the side in which to which trachea deviates.
Yes, trachea is deviated. So trail sign is positive. That doesn't make any sense. Okay. So which side trachea is deviated, we don't know. Just you should know what is trail sign. That's it. But in inspection, you need not mention about trail sign. Just mention whether trachea is central or deviated. That's all.
Okay.
Okay. And apical impulse is not seen. What does that mean? In which conditions it is not seen?
Uh, if there is any pectus excavatum like conditions, or if there is any scoliosis, spine deformities.
No. Apical impulse is not seen in usually obese people.
Yes,
Okay?
yes. Okay.
Obese people or female patients sometimes, or in emphysematous lungs. Okay?
Okay.
And
Okay.
when the apical impulse is behind the rib, you may not see. Okay? So these
Okay.
are the conditions where apical impulse is not seen. So here, 2 points. One is just mention tracheal deviation. No need to mention trail side.
Okay.
And apical impulse
Impulse.
is not in is where in which conditions it is not seen, that you should know. Okay.
Okay. Okay.
Okay. Next.
So skin over the chest wall, no engrossed veins, no scars, no sinuses, no visible swelling, no visible pulsations.
Okay. Next.
Movement of chest, rate is 18 per minute, rhythm is regular, type of normal type of breath. Movement of chest wall decreased on right side. Accessory muscles of respiration were used. Intercostal retractions and subcostal retractions are present.
Okay. Wait here. You have already mentioned respiratory rate and rhythm in vitals.
Yes, ma'am.
Okay. So here
Okay.
again in inspection, you need not mention about rate, rhythm, and type of breath. Okay.
Okay.
So you
Okay.
have already mentioned that abdominothoracic type, 18 per minute, all these things. You
Yes.
should just look at the patient from behind and see whichever side the movement is decreased. Okay.
Okay. Okay.
For posterior regions, and from the front for anterior regions. That is
Okay.
infraclavicular and mammary.
Okay.
So is this movement of chest decreased on all areas on right side?
Uh, Mostly at the axillary, from the axillary region, it is decreased. My mind from memory.
And axillary region, you cannot examine both the axillary regions simultaneously. Okay,
Yes.
so never say
Okay.
axillary region movement of chest is decreased on inspection.
Okay.
Okay, so
Okay.
your examination of chest should be area wise, like in on the anterior part of the chest, supraclavicular, infraclavicular, and mammary.
Okay.
Lateral axillary and infraaxillary, posteriorly suprascapular, interscapular, and infrascapular.
Okay.
Okay, so whatever findings you are examining, all these things should be in these areas.
Okay.
But for movement of chest, lateral part of the chest you leave, because simultaneously we cannot inspect both the axillae. Okay. So
Okay.
either anterior part and both anterior part of the chest should be examined, and
Okay.
mention area wise, whichever area it is decreased, right decreased, and all other areas it is equal on both sides.
Okay.
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 And one more thing, what is normal respiratory rate?
Sorry, ma'am.
Normal normal respiratory rate.
It's between 16 to 21. 14 to 8.
So 18 is
Normal.
normal.
Yes,
Okay,
ma'am.
18 is almost normal. Okay. So when 18 is normal, how can accessory muscles of respiration be used? And also you have mentioned intercostal retraction and subcostal retractions.
Yes, ma'am.
So only accessory muscles of respiration and retractions will be present when there is respiratory distress.
Yes, ma'am.
Okay. So your
Okay.
rate should be much more than 18. So be careful while mentioning such findings. Okay.
Okay. Okay.
So accessory muscles, all these things you should not mention in this case now. Okay.
Okay.
Okay. Next slide.
Palpation. All inspection findings are confirmed. Trachea shifted to left. Apical impulses felt on the left fifth intercostal space, half-inch medial to mid-clavicular line. No intercostal tenderness. Measurements: chest circumference at inspiration it is 84 centimeters, at expiration it is 88 centimeters. Total chest expansion is 4 centimeters. AP diameter is 18 centimeters. And transverse diameter is 32 centimeters. Spino-scapular distance is 6 centimeters on the left side and 7 centimeters on the right side. And spino-acromion distance is 15 centimeters on left and right. So right hemithorax expansion is 40 centimeters and left hemithoracic expansion is 43 centimeters.
Okay, go ahead.
Okay. Oh,
Next.
vocal fremitus, supraclavicular and infraclavicular, it is normal on both. On the left side, it is normal, and right side, it is normal on supraclavicular and infraclavicular region. In the memory, uh, axillary, infraaxillary, suprascapular, interscapular, and infrascapular, it is decreased.
Okay.
The site percussion, site
Next.
of percussion.
Okay. Okay. Go
On
back
the
to
left,
palpation. Wait. Wait.
yes.
Palpation first time. Go back.
Okay, ma'am.
Okay. So your apical impulse is in fifth intercostal space, 1 inch medial to midclavicular line. Right?
Yes, ma'am. Yes, ma'am.
What is the normal location? Where is it located usually, apical impulse?
It's in the fifth intercostal space, mid-clav.
It is half inch medial to midclavicular line normally also.
Mid-clavicular.
So,
Yes, ma'am. It is
okay. So
normal.
you mean to say it is
It's normal.
right?
Yes, ma'am.
Okay. Okay. Because all these points will help in the diagnosis. Okay.
Okay.
So next slide. Okay, this is fine. Next slide. Vocal fremitus say whether equal on both sides or not, because we do not know what is normal for vocal fremitus or vocal resonance. Okay. So when you know,
Okay.
till now you know which is the disease side, which is the normal side, because your respiratory
Yes,
movements
ma'am.
were
Right.
diminished on right side.
Right side.
Okay. So
Yes.
you assume that left side lung is normal. Okay.
Yes,
So
ma'am.
when the vocal fremitus is equal on right side, it is of same intensity as that of left. It is, you should mention that it is equal on both sides. That's it. Okay. Don't mention normal.
Okay, ma'am.
Okay. And
Okay.
for other areas also, you should mention that the vocal fremitus on right side is decreased compared to that of left side. That's all. Okay.
Okay.
So no, don't write normal and all. Okay. Okay. Next.
Percussion. On the left side, it is resonant, and in the supraclavicular region, on the right side, it is resonant, and infraclavicular region, it is resonant. From mammary, axillary, infraaxillary, supraclavicular, interscapular, and infrascapular, it showed stony dullness.
Okay. Always start your percussion with direct percussion
On the clavicle.
on the clavicle and then also sternum.
Okay, ma'am.
Okay. First, normal side you should percuss, then the other side. Okay. And compare it with the normal side. Okay. After
Okay.
direct percussion, then go to direct percussion. Okay. Next.
Tidal percussion, dullness present on the right side, liver dullness at right fifth intercostal space, and liver span is 14 centimeters. Trap space was tympanic. No percussion tenderness, no straight line dullness, no shifting dullness.
Okay. So what is tidal percussion? How did you do that?
So ask the patient to deep inspirement, and
Okay.
while on we'll do the percussion. So usually in the fifth right intercostal space, we'll feel a resonant.
No. You are getting confused. Okay, let me tell you. So first you have to identify the liver dullness. Okay.
Okay.
So liver dullness, you have mentioned here that it is on the right fifth intercostal space, but which line you did not mention. So always liver dullness, you should mention right fifth intercostal space in the midclavicular line.
Okay.
Okay. And also in the mid-axillary line and posterior scapular line also you should mention. So it is fifth intercostal space in the midclavicular line,
Okay.
seventh intercostal space in the mid-axillary line, and ninth intercostal space in the posterior scapular line. Okay.
Okay.
So you got liver dullness in the fifth intercostal.
Yes. Hello.
After getting liver dullness in a particular intercostal space, am I audible?
No.
Yes, ma'am.
Now.
Okay. Okay, you keep your finger on the same intercostal space and ask the patient to take deep inspiration.
Yes.
Okay. So
Okay.
previously, the
Done.
space where you have got dull note, you will get resonant note because of lung expansion.
Yes, ma'am.
Again, you keep your finger in the next intercostal space, that is in the sixth intercostal space, and you again percuss.
Okay.
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 And you see in which intercostal space you are getting the dull note.
Okay.
So usually lung expansion will be one intercostal space. Okay. So
Okay.
you should just mention that tidal percussion is elicited and there was an expansion.
Okay.
Am I clear?
Now it's.
But in your case, because you got dullness on right side, because you said from infraclavicular area you got dullness, no?
Mammary. From mammary.
From mammary area you got dullness.
Yes, ma'am.
Infraclavicular area it is resonant.
Resonant, ma'am.
So how could you cannot elicit liver dullness also in that case. You cannot demarcate no in fifth intercostal space. So be careful.
Okay.
So in case of pleural effusions, if at all it is on right side, you cannot demarcate liver dullness. First of all, you cannot demarcate. And this tidal percussion will help you in differentiating whether this dullness is because of pleural effusion or because of liver enlargement.
Liver. Yes.
Okay. So
Yes.
if the on tidal percussion, if after percussing the on, for example, in the mammary area, you got dull note, and again in the next space, if you are getting again dull note, then it means the lung is not expanding.
Yes, ma'am.
Okay. So if you are getting dull note in the next space, then it is because of liver enlargement. So tidal percussion is to differentiate lung pathology from liver pathology.
Liver. Yes.
Okay. So this you can only do whenever you get a demarcation of resonance to dull note. If, for example, entire right side is dull, you should just mention that tidal percussion could not be elicited because you have no demarcation of resonance and dullness.
Okay.
Okay. And in that case, liver dullness also, what you have mentioned in right fifth intercostal space, that is also not correct. Okay.
Okay.
And if the pleural effusion is on left side, for example, your what should be that this drop space would have obliterated.
Obliterated. Yes.
So these are the findings. If there is some effusion, or if it could be fibrosis, or it could be consolidation, if on right side, you will be seeing a difference in tidal percussion. Okay, so you have to differentiate whether it is pleural pathology or liver pathology.
Yes.
Okay, fine. Next.
Auscultation, breaths, right side decreased air entry in all the areas, and left side it is normal vesicular breath sounds.
Okay.
Auscultation, like vocal resonance, right side it is decreased in all the areas: supraclavicular, infraclavicular, mammary, axillary, infraaxillary, suprascapular, interscapular, and infrascapular. On the left side it is normal.
Okay, next.
So no bronchophony, no echophony, no whispering pectorality, and no added sounds.
Okay, go back to vocal resonance. So you always mention both vocal fremitus and vocal resonance. You should be careful. Both should be same, because in vocal fremitus you have mentioned supraclavicular and infraclavicular area. They are equal on both sides.
Yes, ma'am.
Am I right?
Yes, ma'am.
But here you have mentioned it as reduced.
Yes, ma'am.
So it is the same counterpart. One is in palpation, the other one is auscultation. It is the same finding. So you should not mention both findings differently. Okay. So both should be same.
Okay.
So whichever you are more confident of, write the same thing in both places. Okay.
Okay.
And bronchophony, egophony, all these things you only mention when there is increase in vocal resonance. Otherwise, you need not mention about bronchophony, egophony, and whispering pectorality. Okay.
Okay.
These things you will find only when there is increase in vocal resonance.
Yes.
Otherwise, you need not mention about those things.
Okay.
Okay, next.
Other systems, see, cardiovascular system, S1, S2 heard, no murmurs were heard. Central nervous system, no focal neurological deficit. Abdomen, soft, non-tender, and no organomegaly. Diagnosis: right sided massive pleural effusion. Etiology is of infective cause. Query tubercular effusion without respiratory distress and without complications, but still I would like to rule out malignancy.
Okay. So what are the points in favor of pleural effusion? Starting from history.
Okay, ma'am. There is a pleuritic type of pain,
Okay.
uh, and there is a shortness of breath which is decreased while on the opposite side,
Hmm.
and that is there. And the
Okay. Let me tell you. So in respiratory system, the pathologies would be involvement of pleura,
yes,
involvement of parenchyma, involvement of interstitium or airways. Okay. So broadly, any disease would fit into these four headings. Okay, pleura, parenchyma, interstitium, and airways. Okay. So in this case, you think of pleural involvement because of chest pain.
Yes, ma'am.
Okay. So what are the characteristic features of pleuritic type of chest pain?
It is a sharp stabbing type of chest pain, which is aggravated and deep inspiration or coughing.
Okay. That is fine, but pleuritic type of chest pain will only be present in the initial period of pleurisy. Okay. So
Okay.
as the fluid starts accumulating, this classical presentation of pleuritic chest pain will not be there. Okay.
Okay, ma'am.
There will be heaviness in the chest, and shortness of breath will dominate this chest pain. Okay. So your
Okay.
classical picture of pleuritic type of chest pain, that is pricking type of pain, which is increasing with inspiration, all these things will be present only when there is pleurisy. Okay. So
Okay.
as fluid goes on accumulating, you will not get that classical picture. And
Okay.
one more thing is why I asked you about sputum, because in pleural involvement, if there is involvement of only pleura, patient will not have sputum.
Yes, ma'am.
Okay.
Okay.
So sputum will be present whenever there is a parenchymal disease, or sometimes whenever there is an airway disease like chronic bronchitis. Okay.
Yes, ma'am.
Otherwise, in interstitial lung diseases or pleural diseases, you will not have sputum. So that's why I asked you, whenever you are mentioning about sputum, which is not
It's
it is
scanty.
very negligible, you
Okay.
omit that.
Okay,
Okay.
ma'am.
So because whenever you are concluding for the provisional diagnosis, again it will be a negative point.
Okay, ma'am.
Okay. So chest pain, breathlessness, and shortness of breath. All these things with cough,
Cough.
dry cough. All these things point towards involvement of pleura.
Pleura. Yes.
Okay. And you said patient is more comfortable when he is lying down on which side?
Left side.
Okay.
Opposite.
Usually in unilateral lung diseases, uh, in this patient has right-sided pleural effusion, right? So
Yes.
whenever there is pleural effusion or pneumonia, whenever the entire lung is involved only on right side, patient has more distress when he is lying down on the same side. That is because of VQ mismatch.
Yes, ma'am. Ventilated perfusion mismatch.
Okay, so ventilation perfusion mismatch, he will be having more breathlessness when he's lying down on the same side. So he's more comfortable when he's lying down on the opposite side.
Okay.
Okay, so that point I wanted to stress. Okay,
Okay.
so
Okay.
because most of the because that chest pain, pleuritic type of chest pain, whenever it is present, patient is more comfortable when that patient is lying on the same side. You understand the difference?
Yes, ma'am. Okay.
So initial stages of pleurisy, when patient is lying down on the same side, he is more comfortable because the friction between the pleura is reduced when patient lies down on the same side. But
Okay.
as the fluid goes on accumulating, when the patient lies down on the same side, patient feels more breathless because of VQ mismatch.
Okay.
Okay, so that
Okay.
is involvement of pleura, that is fine. Then right-sided pleural effusion, how did you say? Effusion, what are the points in favor of effusion?
The inspection, auscultation, auscultatory findings, and
So tell
palpation
me, what are
findings.
the points? What are the points favoring effusion?
Okay. Uh, uh, Inspection, there is a right-sided reduced chest expansion.
No, no, start from trachea.
Trachea, okay, ma'am. From trachea, it is deviated towards the opposite side,
Okay.
and from its inspection, there is a reduced expansion of chest on the right side,
Okay.
and on auscultation there is reduced
No, in
decay.
between palpation, percussion are
Palp-
there.
yes, ma'am. On palpation,
Your apical impulse,
there is a tracheal shift on the left side.
that is okay. What
Apical
about
impulse
apical
is
impulse?
normal. Sorry, ma'am.
It is normally located.
Yes, ma'am. Normal. Apical impulse is normal.
Okay. So then how do you say it is pleural effusion?
Since it is the left side apical impulse, so there is no
Hmm.
left side pathology.
So,
If it is a left sided pleural effusion, we may not have felt the
no,
apical.
no, no, no. Pleural effusion, if it is there on any side, right side or left side, it will shift the mediastinum to opposite side. Okay. So
Okay.
since pleural effusion, what is pleural effusion? It is accumulation of fluid.
Fluid in the fluid.
Okay. So fluid will start accumulate from downwards and it will
Downwards.
go on accumulating upwards. So first your shift should be in the lower mediastinum.
Okay.
Then only if there is massive effusion, there will be tracheal shift.
Okay.
So your first point should be apical impulse should be deviated because fifth intercostal space half an inch medial to midclavicular line is normal. If the fluid is on the right side, it should be either on the midclavicular line or it should be lateral to midclavicular line.
Okay.
Okay. So this apical impulse shift should be definitely present if there is pleural effusion.
Okay.
Okay. And always remember for moderate effusions, it will be only the lower mediastinal shift. That is apical impulse will be deviated in moderate effusions. If it is massive effusion, both lower mediastinum and upper mediastinum, that is apical impulse will be shifted and also trachea will be shifted.
Okay.
Okay, so if you are saying massive pleural effusion, only shift of trachea would be wrong.
Okay.
It would be only shift of trachea would be wrong, and apical impulse should also be shifted. And if you think there is pleural effusion and apical impulse is not shifted, then there should be some other pathology. But since you are mentioning only pleural effusion, both apical impulse and trachea should be shifted. Okay.
Okay.
And then percussion.
And percussion, there is a stony dullness on the right side from the mammary region to axillary,
Almost low.
infraxillary, and yes, stony
Posteriorly
dullness.
also stony dull note. Okay. Then auscultation.
Auscultation decreased breath sounds on the right side.
Okay. And what about shifting dullness?
Shifting dullness, it is absent. No shifting dullness.
So do you see shifting dullness in pleural effusion?
Yes, ma'am. Shifting dullness is delayed in can be seen in pleural effusion.
Okay. So why do you think here in this case pleural shifting dullness is not present? So shifting dullness may not be present when there is massive pleural effusion. Okay. Or
Okay.
when the pleural fluid is loculated. Pleural effusion is loculated. In both these conditions, shifting dullness may not be present. Okay.
Okay.
Okay. And on auscultation, one more point I wanted to add, that is in massive pleural effusions, above the level of pleural effusion, sometimes we may hear egophony.
Yes, ma'am.
You will be seeing increased vocal resonance and egophony. In this case, you said in the till mammary area, you got dull note, and after that it is resonant note. Okay. So
Yes.
at the level of fluid, I mean, just at the demarcation where the fluid and air is present, if you hear properly, you may sometimes hear increase in vocal resonance along with egophony, so which we see in cases of massive pleural effusions.
Okay.
Okay, so here in this case, pleural effusion, so okay, with tracheal shift, decreased resistance on right side. Apical was also be shifted actually. Then on percussion, the load and an auscultation reduced to absent, sometimes absent breath sounds. Okay, so these are points in favor of pleural effusion. Now coming to etiology. Okay, pleural effusion. So etiology possibility could be tuberculosis. So why tuberculosis? Why malignancy?
Tuberculosis because he is having a fever since 1 month, and decreased appetite.
Okay. And there is evening rise of temperature.
Evening rise of temperature, yes, ma'am.
Okay. So malignancy?
Even in the malignancy, there is a decreased appetite, but even they have a chronic like fever since many days.
Yes, fever. Again, fever is a feature of malignancy.
Yes.
Okay. And then one more point in favoring malignancy.
He's a smoker.
Yes, smoker. So because considering what was the age of the patient? 50,
50
no?
years. Yes.
Okay.
Age of
Middle-aged patient with history of fever. 1 month history of fever with evening rise of temperature. In India, first possibility we should suspect tuberculosis.
Tuberculosis, yes.
But because patient is also a smoker,
Okay. Yes.
you should also rule out malignancy.
Malignancy, yes.
Okay. So what are the markers of malignancy? You said some external markers of malignancy, no external. What will you see in malignancy?
Like acanthosis nigricans, gynecomastia, and stains over the nails.
Stains over the nails is not a sign of malignant. It will just tell you about the addiction. So you should look for lymph nodes.
Lymph nodes.
Okay. So you should look, in this case, you said already no lymphadenopathy, but you should be careful. Okay. So lymph node, you should more inspect more carefully. And how will be the lymph node if at all it is malignancy? On examination. It will be usually single node.
Okay.
Hard in consistency and non-tender.
Okay.
Okay, single hard node with no tenderness is suggestive of malignancy. In tuberculosis, usually it may be single or multiple. If at all it is multiple, they are more matted.
Okay.
Okay. So, and you said 1 month history of fever, you are considering a diagnosis of tuberculosis. When do you call a person as a case of presumptive TB? Previously, we used to call TB suspect.
Okay.
Okay, so now that suspect term is removed and we are calling them as presumptive cases of TB. Whenever a patient has history of cough, okay, loss of weight, loss of appetite or fever for at least 2 weeks,
Okay.
we should, that person is known as presumptive case of
Presumptive TB.
TB. Okay.
Okay.
Because here it is 1 month history of fever, definitely you should consider the diagnosis of tuberculosis.
Tuberculosis.
Okay, so here without respiratory distress and without complications, you need not mention. If at all they are there, just mention, otherwise omit them.
Okay.
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 If complications are present, just mention. That's it. So Pradeep. Okay, few more minutes. Just tell me how do you proceed for.
Sorry.
Madam, your voice is not clear, ma'am. Please just repeat the question again.
Am I not audible?
Now it's
Now it's clear, ma'am.
No. Shall I continue for few more minutes?
Yes, ma'am, you can continue.
Okay. So how do you investigate this case?
Ma'am, I'll do the diagnostic pleural tap, and I'll send for uh, pleural fluid analysis.
Okay.
I'll look for cell type, cell count.
So before going for all specific investigations, you should start with complete blood picture for just like any other case. What will you see is complete blood count?
Uh, lymphocytic predominance.
No.
Oh,
In a tuberculosis case in CBP.
okay. Oh. Raised WBC counts.
No. Raised WBC counts will be seen whenever there is empyema.
Okay.
Okay. So
Okay.
mostly we'll be seeing anemia.
Okay.
Anemia of chronic disease. Okay. WBC counts may be normal with raised ESR.
Yes, ma'am.
Okay. Leukocytosis, if at all it is present, then there is some pus in the pleural cavity.
Okay.
Okay. It could be mostly empyema. Then other investigations.
We check for blood sugars, RBS, and serum LDH, LFT, liver function test.
Liver function test. Why are you doing that?
To rule out hypoproteinemia, whether it is causing the pleural effusion or not, or to make sure in the lights criteria it is help to compare the proteins.
Okay. Then
Uh, Even serum LDH to look for exudative or transitive type of fluid, and then we go for pleural fluid analysis.
okay, you have to get complete blood picture. Okay.
Yes.
Liver function test, renal function test. Okay. Viral markers. Okay. You have to rule out HIV also because there is
HIV. Yes.
fever. Okay. Fever and loss of appetite, all these things. Okay. Then your chest X-ray.
Yes, ma'am.
Then you have to go for pleural fluid aspiration. Before pleural fluid aspiration, it is always advisable to go for ultrasound chest.
Okay.
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 Okay. So then in pleural fluid, you will be seeing the values of pleural fluid protein, pleural LDH, and
Amylase
somebody has
lipase.
mentioned rule out diabetes. Diabetes. Yes,
Yes.
sugars also you have to rule out. Okay. You have to
Yes.
measure.
Yes.
Yeah.
Serum fluid amylase levels also.
Why? Why are you thinking of any?
Pancreatic. Any
No,
pancreatic.
if you are suspecting some pancreatic tumor or if you are suspecting some esophageal tumor, then only you advise amylase. For every case
Yes.
of pleural effusion, you need not go for amylase. Okay.
Okay.
So
If it is
first you have
presiding.
to rule out whether it is a transudate or exudate.
Yes, ma'am.
So what do you suspect even before going for lights criteria, whether it is transudate or exudate with clinical examination features? Would it be exudate or transudate?
Exudative type of pleural effusion.
Okay, because there is fever and there is unilateral pleural effusion, which is mostly seen in exudative condition, mostly
Exudative.
transudative condition. Majority of times it is bilateral pleural effusion. Okay.
Okay.
But it is not in all cases. Okay. So for
Oh,
the sake of suspicion and in what investigations you have to send, what are the immediate investigations, for that you have to have some clinical background. Okay.
okay, ma'am.
So lights criteria, you know already. So what is modified lights criteria?
Modified lights.
In modified lights criteria, let me tell you, it is apart from protein levels, we also measure the pleural fluid cholesterol.
Pleural. Okay, ma'am. LD.
Okay, so that is modified lights criteria. So in some cases of transudates, when patient is using diuretics, it is misdiagnosed as exudate. Okay, in those cases, we also should look for the gradient, pleural fluid and serum, protein or albumin gradient.
Okay, ma'am.
Okay, so if it is more than 1.2, that is albumin is more than 1.2, it is transudate.
Okay.
So apart from lights criteria, you also should always look for the gradient also.
Okay.
Okay. So you send for what investigation? All these pleural fluid investigations?
Okay. Yes, ma'am.
You said something, AD and all? Pleural
LDH.
fluid.
Fluid.
Uh, am I
Yes.
audible?
Yes, ma'am, you are audible.
Okay, okay. So you have to send for pleural fluid for microbiology. Okay, you have to send for gram stain,
Yes, ma'am.
culture sensitivity,
Glucose,
AFP,
protein,
glucose,
LDH,
proteins,
AD.
ADA,
Yes, ma'am.
cytology, cell block.
Yes, ma'am.
Okay, so all these investigations, CB-NAT.
Yes, ma'am.
Okay, so these investigations you should send. So once you know that it is exudate, so what are the points in favor of tuberculosis? So among all these, what investigations will give you a diagnosis of tuberculosis? Though
So,
not a definitive
fluid,
diagnosis,
fluid. Okay, ma'am.
tell me.
Pleural fluid protein and serum protein, comparing that, and serum LDH and pleural fluid
No,
LDH.
that is okay. That you have differentiated that it is, you already know that it is exudate. Okay, pleural.
Yes, yes, ma'am.
Pleural fluid protein by serum protein is more than 0.5. LDH is also more than 2/3. Okay. Now, to say that it is tuberculosis,
Okay.
pleural fluid cytology, there is lymphocytosis.
Yes, ma'am.
Sorry. And also, ADA more than
Oh,
okay, so these are points in favor of tuberculosis. But ADA may be also
tuberculosis.
elevated risk of empyema also. Okay. But other
Okay.
points like
Okay.
very low glucose or neutrophilia or all these things will give you a clue to the diagnosis of empyema. Okay.
Okay.
If you are suspecting malignancy, you should always send for cell block.
Oh, yes, ma'am.
And pleural fluid cytology, you should send for 3 separate days. Okay, so first day when you are aspirating and sending for cytology, you have chances of getting only 60%. Okay, so
Okay.
on third day, it may increase to 90%. After
Okay.
3 days of separate thoracocentesis report, even then, if the malignant cytology is negative, then we go for pleural biopsy.
Okay.
Okay.
Okay, ma'am.
So, if in pleural fluid analysis, if we are not getting the definitive diagnosis, then you can go for biopsy. So, it could be closed biopsy or it could be open biopsy. Okay. So,
Okay.
you can go for thoracoscopy, medical thoracoscopy, or surgical thoracoscopy, that is known as video assisted thoracoscopy for
Thoraco.
biopsy.
Okay, ma'am.
This biopsy sample, again, we have to send for HPE,
Okay.
histopathological examination, and also for culture,
Culture.
mycobacterial culture.
Okay, ma'am.
Okay. So once you got the diagnosis that it is tuberculosis, then what will you do?
Start anti-tubercular drugs.
So what is
Beds,
the
bed.
regimen? Hmm?
So, uh, 6 months of
6 months of ATT
ATT. Yes, ma'am.
with 2 months of HRZD and 4 months of
4 months of HRE.
HRE. Okay. So somebody has written if it is rifampicin resistant, what to do then? If it is MDR tuberculosis, then
We start other regimens like B-PAL regimen.
okay. So MDR treatment, it includes bedaquiline, linezolid, levofloxacin, clofazimine, okay, high dose of INH, ethambutol. So now we are not using the longer regimen, okay. So shorter regimen with in first group of drugs like bedaquiline, linezolid, uh, fluoroquinolones in the intensive phase. Okay, so and injectables. If at all patient is not responding to drugs, then only we are changing to other regimens. Okay, containing injectables. Otherwise, now injectables are mostly not given to MDR TB treatment patients.
Okay.
Okay. If it is a case of malignancy, so you know that it is malignancy and there is massive pleural effusion. What will you do?
So therapeutic pleural tapping.
Okay, so if it is massive pleural effusion, how long can you tap? Okay, so you have to put
Thoracogen, like intercostal drainage.
yes, intercostal drainage. Then, so after draining most of the fluid, then you have to do a procedure known as pleurodesis.
Okay.
Okay, so pleurodesis is nothing but we are creating inflammation between the two pleura so that both the pleura adhere to each other.
Okay.
Okay, so the agents used in pleurodesis are talc, okay,
Yes.
minocycline, doxycycline, povidone iodine. So all these agents lead to inflammation. Okay. So whenever you suspect massive recurrent effusions because of malignancy, you have to do fluorodesis so that the fluid doesn't reaccumulate again.
Okay.
Okay, but not in all cases of malignancy, you have to see whether if at all the lung is expanding, then only you should consider for fluorodesis. For example, on the side of pleural effusion, if there is intrabronchial growth, okay, this growth, if it is not allowing the lung to expand, even if we do fluorodesis, it will not benefit the patient.
Yes.
Okay, so in those cases of massive pleural effusion where there is also intrabronchial growth, okay, where fluorodesis may not benefit,
I
we
want to
have
make one. I went to. Yes, because I went to water.
we
Yes,
put
point
indwelling pleural catheter. Okay, so this catheter, whenever patient has breathless, he can evacuate the fluid at 200 ml or 500 ml per day, like that. Okay, so only in cases of massive effusion where there is a shift of mediastinum to the opposite side and there is no intrabronchial pathology, there in those conditions, intercostal tube drainage with fluorodesis will benefit the patient. If there is, along with pleural effusion, some intrabronchial pathology, only you have to place an indwelling catheter where patient will drain daily whenever there is breathlessness.
Breathlessness.
Okay. Okay. Any doubts? If at all, if anybody has any doubts, I can clarify. Somebody has written in exam, there's nothing called routine. Yeah, just I mean, for all cases, you have to start with investigations of complete blood picture, LFT and RFT, which will help in this case also. So you have to list all the investigations we have to do for that patient. Okay.
Okay.
And therapeutic tapping, what is the role of therapeutic tapping? Whenever a patient has distress, okay, you have to drain, I mean, for diagnostic purpose as well as therapeutic purposes. Okay, how much should we drain? We should not drain more than 1 liter in one setting. Okay, and what are the complications of tapping? Infections, hemorrhage, shock. Patient may land up in shock sometimes. And if we are draining long-standing pleural effusions, massive long-standing pleural effusion, patient may land up in re-expansion pulmonary edema. So suddenly lung opens up and there may be pulmonary edema. Okay. So what is the indication of ICD in pleural effusion? ICD should be put in pleural effusion when you think it is purulent. Okay. Empyema, it is a definite indication of ICD. And whenever there is both fluid and air, hydropneumothorax, again ICD is an indication. And hemothorax, whenever there is collection of blood in the pleural cavity after a trauma, again it is an indication of ICD in pleural effusions. Okay, so in pleural effusions, it is empyema, hemothorax, hydropneumothorax, then in malignancies, massive pleural effusion, which you think it is because of malignancy, all these are indications of ICD. Okay. Usually straw-colored fluid would be seen in cases of tuberculosis.
Tuberculosis.
Chemical fluorodesis and mechanical fluorodesis are not both same. Chemical fluorodesis, we introduce these chemicals like talc, whatever I have told you, minocycline, doxycycline, povidone, iodine. Mechanical fluorodesis, usually there is an abrasion done on the pleural abrasion. Okay. So that creates inflammation and both the pleura adhere. So chemical and mechanical fluorodesis are different. DCLD, decompensated liver diseases, ICD insertion is not indicated because it will increase the morbidity and mortality because there is continuous drainage and definitely patient will land up in more severe condition. Paranemonic effusion and synemonic effusion difference is nowadays synemonic effusion we are not using. Paranemonic effusion, the organism in pneumonia, whatever organism we are isolating, the same organism will be isolated in effusion also. That is paranemonic effusion. In synemonic effusion, the organism may not be isolated at all in the pleural effusion in cases of synemonic effusion. Okay. There is one more term known as metanemonic effusion, where the organism isolated from the lung parenchyma, that is from the sputum, is different from that of pleural effusion. That is metanemonic effusion. Okay. Hope I am clear.
Yes.
So shall we end the session?
Yes, ma'am. Can end the
Okay.
session. Thank you, ma'am, for having us a wonderful discussion. And it was very informative for all the residents who have joined. We hope to have such sessions in future too. And thank you, Dr. Raviteja, for presenting this case. And the audience for this sessions. Hope to
Okay.
come up
Thank
with
you,
new
everyone.
sessions. Thank you, ma'am. Thank you, everyone.
Thank you.
Thank
Thank
you. Thank you for giving me this opportunity. And Raviteja, it was an excellent presentation. Being a first year resident, you have done well.
Okay, ma'am. Thank you, ma'am.
Thank you. Thank you.
Thank you for giving this opportunity for Dr. Pradeep sir.